Thanks, Angie, for that great intro. Hi, I'm Dr. Heather Hydzik. Today, I will be going over basically the dessert of all of the presentations from the year. So I'm going to answer your most frequently asked questions about hormone and neurotransmitter testing. Starting with general types of questions. Why should you test hormones and neurotransmitters together? On the slide, I wrote the scientific answer, but the clinical reason is that there are a number of symptoms that can be a result of either neurotransmitter or hormone imbalance, and testing both casts a wide net so you can see which ones are off and then narrow down your treatment. And these are all of the interactions between hormones and neurotransmitters that could fit into one graphic. And I'll walk through one example. Estrogen plays a large role in temperature regulation, but it also increases the receptor activity for serotonin and the production of serotonin. Serotonin also affects the body's temperature regulation. And this kind of helps me understand why supplementing estradiol and SSRIs can both help reduce hot flashes. If you need to prioritize testing, you can base your decision on the symptoms you intend to treat and their most likely cause. And we also take into account the patient's age and their stage of life. So if you're thinking about what tests to do for children, neurotransmitters and possibly cortisol testing would make sense for them. If someone has mental health or behavior symptoms that aren't related to classic hormone transition times, then think about neurotransmitters. And if your patient presents with anxiety, you might think about neurotransmitters first, but if this is a postmenopausal female and the anxiety came on during that transition, then you might think about hormones. There are 3 ways to test hormones. You can use saliva, serum, or urine. Serum is the only method that is consistently covered by insurance, but it's not appropriate for monitoring transdermal hormone supplementation, especially progesterone and testosterone. Saliva is the best for these. And then when you're testing saliva, you have 2 panels to choose from, the comprehensive or the comprehensive plus. Remember, the comprehensive plus is the one that includes all 3 estrogens. You would choose that if your patient is a female over age 45, or if they have a family or personal history of estrogen-driven cancers. And if you have any concerns about detox pathways or how hormones are being converted or metabolized, or maybe you gave topical hormones, everything's in range on saliva testing, but symptoms are still not under control, then you can look at the HUMAP, which is a urine test, to see if there's an issue with hormone metabolism. When should I follow up after testing? You are going to want to follow up any hormone balancing treatment at about the 12-week point to just make sure you're going in the right direction. And this includes following up on cortisol supplementation. If your patients are on bioidentical hormones, once you've achieved a stable dose and good symptom control, then you can follow up yearly. And you want to retest the HPA axis at about 6 months to 1 year. Symptoms for that will start to improve sooner, but it does take time for the HPA axis to recalibrate. And neurotransmitters are similar. If you're going to follow up, you might do that at the 6-month point after initial testing, but you also might retest sooner if symptoms change or if response to treatment changes. For help with interpreting results, we have staff physicians on call to answer your questions weekdays, 8 to 4 Pacific time. You don't need an appointment. And now I'm going to answer questions about our newest test offering, the HUMAP, which tests hormones and their metabolites in urine. As to the clinical utility, urine testing demonstrates how hormones are being metabolized and specifically how phase 1 and phase 2 detoxification of estrogens is going. And this might underlie patient symptoms or impact cancer risk. This can lead to specific treatments to target certain areas of metabolism or detoxification. The HUMAP test is appropriate for cycling females, postmenopausal females, and for males over age 12. There isn't a reference range for pregnant females developed yet, so it might not make sense to test that population. Some of the most common reasons for ordering this test so far seem to be breast health, PCOS, prostate health, fertility, or just in general to look at how hormone metabolism might be affecting hormone balance. And the HUMAP can allow you to gain insight on the conditions listed here in this box. Salivary and urine hormone testing are looking at two different aspects of hormone balance. Salivary testing reveals levels of biologically active hormones available to the tissues. This is the best choice if you're monitoring hormone supplementation because it can reflect proper dosing of hormones delivered by any route. Urine testing is going to show you how these hormones, whether they are your patient's own hormones or supplemented hormones, how they're being metabolized, detoxified, and eliminated. And hormone metabolite ratios can demonstrate how enzymes involved in these processes are performing, and that can lead to specific treatment considerations. If you're seeing a pattern of low hormones on a urine test, we recommend a reflex to salivary testing to confirm the low levels before considering BHRT. We don't recommend using urine testing to adjust BHRT doses because of the physiology of hormone absorption, transport, and metabolism. Transdermal application delivers bioidentical hormones to the capillaries underneath the skin, and then the hormones travel attached to the membrane of RBCs, red blood cells, and that goes directly to the tissues. Topical supplementation is then going to be reflected in saliva, but blood and urine levels will only increase if the transdermal doses exceed the carrying capacity of the red blood cells. Orally delivered bioidentical hormones will go through hepatic first pass metabolism, and they'll mostly be excreted in stool and urine. Because more of the oral bioidentical hormones passed through the digestive system, the metabolite levels tend to appear really high if you test urine after taking oral hormones. And this won't mean that the dose is high, it's simply reflecting the expected metabolism. And that's why you can't really check if your oral hormone dosing is right using urine because the levels are going to be high. However, the HUMAP can be a really good tool to track metabolism patterns for supplemented hormones. For instance, if an estradiol patch is causing an increase in 4-hydroxyestradiol or 4-hydroxyestrone, additional measures could be used to lower the potential of the exogenous estradiol to contribute to breast cancer risk. So in this case, the dose of the estradiol patch wouldn't necessarily need to change, but the way the patient is metabolizing these exogenous estrogens would be the main focus of treatment. So then you could consider things like DIM, support for the COMT enzyme, flaxseed, calcium D-glucarate, ensuring the patient is having regular bowels. So yes, the HUMAP can inform treatment decisions for patients on BHRT. Here's another example. This is the androgens and the estrogens section for a 65-year-old male who is using 100 milligrams of transdermal testosterone. He's clearly aromatizing his testosterone to estradiol, flooding the whole estrogen neighborhood on the right. And I wonder if he ended up on such a high dose because he converts so much of his androgens to estrogens that he's been having trouble to benefit from the additional testosterone. And when you see this pattern, considerations could include treatments that inhibit aromatase. The HUMAP is done from a liquid urine collection. There's no need to reconstitute it, and creatinine can be measured directly. And DDI tests additional methoxyestrogens via both estrone and estradiol. So there are more analytes on this test compared to some of the other urine tests out there. We also differentiate between 5-alpha-pregnanediol and 5-beta-pregnanediol metabolites of progesterone, and we measure progesterone itself, as well as allopregnenolone and androstenedione. And the HUMAP report has a lot of information on it. It's really extensive, but DDI made sure that the first 2 pages of the report show you everything you need that you can look at quickly with really easy to read graphs, visuals, color coding that can allow you to interpret this quickly, and it doesn't take forever to understand what's in the report. So page 1 is showing you the most clinically relevant information, and page 2 shows you where all of the hormones and metabolites come from, where they're going, which enzymes are responsible, and the color coding will change based on your patient's results. So red, we usually think of as hot, so those would be high levels, and then blue we think of as cold, so that would be lower. So you can just glance at this and see everything we tested. And you have the option to add on neurotransmitter testing to the urine sample. So that's another thing that DDI offers. Now we're going to talk about questions regarding collecting urine for the HUMAP. And we've got a number of these. Probably you will have to stop taking hormones prior to collecting urine, depending on the route of delivery of your prescription, meaning is it sublingual or topical or what? And you might have to wait a certain amount of time after your last dose before collecting, and then also wait until after the last urine sample is collected before resuming your regular hormone dosing schedule. So that might be as much as 72 hours off of the hormones. And note that because of the different ways that hormones enter the body and are metabolized depending on route of delivery, the dosage intervals for urine testing and saliva testing are going to be really different. For night shift workers, collection times should correspond to the patient's pattern of eating and sleeping. And the same thing goes for saliva collections. So the waking collection is going to be done after a person wakes from their longest stretch of sleep, whether they're a person who sleeps at night or if they're a person who sleeps during the daytime. If the patient has to void 1 to 2 hours before the assigned collection time, they can go ahead and collect the sample early. It's just best to collect urine from a full bladder when there's been at least 2 hours since the prior urination. And then if a patient can't collect at the requested time, they should make sure to hydrate and then collect as soon as they can. So just remind people to drink water if that's not something they do. Urine samples have to be frozen at least 4 to 6 hours prior to shipping. 2 hours is not going to be enough. And speaking of urine testing, now we're going to talk about the most common neurotransmitter questions that have come in. So this is the biggest question that I think we get asked the most. Does this testing measure brain levels of neurotransmitters? And the answer is no. That would require a spinal tap, which is not necessary, nor is it ethical. And it's not necessary to isolate the neurotransmitters that are in the brain, because neurotransmitters don't only function in the brain. They're secreted in the central and the peripheral nervous system, and the enzymes that regulate them are nearly identical on both sides of the blood-brain barrier. We're not measuring what's in the synapse, but urine testing likely reflects whole body production. And urinary neurotransmitter testing is a good general guide to treatment, and it correlates really strongly with symptoms. We've seen this in our clinical experience, and there also have been published studies on urinary neurotransmitter validity and clinical applicability. Here's a really good one at the bottom of the slide. So if you're trying to choose between running the NeuroBasic or the comprehensive neurotransmitter profile includes everything tested on the NeuroBasic. So that's serotonin, dopamine, norepinephrine, epinephrine, and so on, everything in purple on this chart. And then the comprehensive includes also what I circled in green. And those are mostly metabolites and also amino acid precursors to the neurotransmitters. Both of these are going to help you evaluate for deficiencies or excess levels of neurotransmitters. And you can also look for the need for certain nutrients in your patients, and that can open the door to working on nutrition. The comprehensive neurotransmitter profile lets you see how neurotransmitters are being metabolized, and you can also figure out how the COMT and MAO enzymes are functioning. And whether or not you know if your patient has a genetic variant for one of these enzymes, only by testing these metabolites and the precursors can you really see how fast or slow the enzymes are working. For example, if you run the NeuroBasic and you found normal norepinephrine and then low epinephrine, you might think about supporting the epinephrine levels by supplementing SAMe and then giving HPA axis support to improve the cortisol levels. But if you've done the comprehensive, you can check if norepinephrine and medinephrine are higher than the neurotransmitter that they're coming off of. And that would tell you if COMT is maybe working too fast. And maybe that's why epinephrine's too low. So you can help counteract this effect by supporting the MAO enzyme with vitamin cofactors like B2, B3, pyridoxal 5-phosphate, magnesium. How long do you need to supplement amino acids before retesting? We recommend supplementing at least 6 months before retesting. Neurotransmitter levels change fairly slowly, kind of like cortisol, and patients will most certainly start feeling better before then. Long-term support beyond 6 months may be necessary for symptom management, but you might also be able to discontinue the amino acids sooner if the patient is working on improving diet and digestion and lifestyle change, sleep hygiene, exercise, and so on. You can definitely test patients who are using psychotropic drugs, and a lot of providers are testing patients using these medications. The results are going to reflect the influence of the medication, which can actually be hard to predict without testing. And most of the time, patients aren't tested prior to initiating a medication like an SSRI. So we can't say for certain how the neurotransmitter levels change for everybody. But I do often see low serotonin levels in patients who've been taking these medications long-term. And there is research out there supporting that this happens a lot of the time. For patients who are discontinuing medications, how long do they need to stop after, how long do they need to stop the psychotropic drugs before seeing baseline neurotransmitter levels? So it takes about 5 half-lives for 95% of the medication to be eliminated from the body. And generally, depending on the half-life of the drug, which I listed a lot of the common ones here, it takes about 6 to 8 weeks. I want to emphasize that you don't have to stop medications like anti-anxiety meds, antidepressants in order to test neurotransmitters. It could cause withdrawal. It could cause return of the symptoms you're trying to treat. And this information is more meant for patients who are in the process of stopping their medications and want to know when they'll see their baseline levels. Patients can definitely take amino acids while they're using psychotropic drugs. The safest way to do this is to look at their neurotransmitter levels while they're taking the medication to check if the neurotransmitter you're thinking of supporting with amino acids is actually low or lower range. So you can definitely combine 5-HTP and an SSRI, but you just want to make sure that the patient needs it. So there are a number of common drugs that have a negative impact on neurotransmitter levels. So that would be psychotropic medications and any prescription that depletes cofactors. As you can see on this list, a lot of common medications deplete the vitamins we need for synthesis and metabolism of neurotransmitters, including antacids, antibiotics, and even birth control pills. And I often get asked which neurotransmitters are affected by the long list of medications a patient is on. And so I made a chart of all of the medications I could find that affect neurotransmitters and whether they increase or decrease the neurotransmitter or affect the receptors. And just know that if something agonizes or increases the levels of a neurotransmitter, that doesn't mean it's going to be high on the test, just that it's probably higher than it was before the patient started the medication. How will cannabis affect the results? THC and CBD are the main phytocannabinoids in cannabis, and they affect neurotransmitters differently. THC in the short term elevates dopamine, but then long-term use can lead to depressed levels of dopamine and glutamate. CBD, regular use increases serotonin, and CBD can also activate glycine receptors. Glycine is a neurotransmitter that can improve mental performance, memory, and sleep quality, and it's anti-inflammatory. Is creatinine diagnostic? No, creatinine for the purpose of this test is an indicator of how concentrated the urine is. It's not telling you anything about kidney function, and we just use it to calculate the neurotransmitter levels from a single void sample. It doesn't have any diagnostic value. If the creatinine is lower, that means the urine was more dilute at that time. If the creatinine is higher, the urine was more concentrated. Now I'll talk about what's important to know about sample collection for neurotransmitter testing. You have a few choices to decide, are you going to do a 24-hour or a spot collection? 24-hour collection allows you to measure the average excretion of neurotransmitters throughout the day, and it reflects the influences of food and stressors that happen throughout the day. It's the only viable option if your patient has kidney disease, but compliance can be difficult, and even if someone misses one sample throughout the day, that can skew the results. Spot testing, which means either a first morning void or a second morning void, allows you to measure baseline neurotransmitter levels, and they won't be influenced by foods eaten throughout the day and stress. And this is the more convenient and more popular option. Second void used to be the industry standard for a long time, and a lot of providers are comfortable using this, but further research showed that collecting the first morning urine sample is just as reliable, if not more so, in order to capture baseline levels. And second void can be difficult for patients because they have to wait several hours to eat or drink coffee or exercise. And personally, I recommend first morning void for patients, and I think this is the most popular option that providers choose. Whichever you prefer, just make sure you're always ordering the same one. Bananas and other foods on these lists increase serotonin or catecholamine levels, and catecholamines means dopamine, norepinephrine, and epinephrine. The foods need to be avoided for 48 hours prior to NT testing, and the substances, meaning caffeine, nicotine, and alcohol, as well as strenuous exercise, have to be avoided for 24 hours before testing. So I get this call a lot. My patient will not avoid the food or stop smoking. Is that okay? And the test is going to give you the most valuable information if the avoidances were completed as instructed. Consuming certain items can make the test interpretation more difficult, but for patients who smoke or vape tobacco every day, you can try to have them stop smoking as early as possible the day before. Some patients find it easier to do this if they go to bed early, and if they have a lighter dinner, that can help reduce the urge for smoking after a large meal. And they can also try to cut back for a few weeks before the test to try to achieve as long of an interval between tobacco and sample collection as possible. Now we're going to talk about the cortisol awakening response. This is the rise in cortisol that happens 30 minutes after you wake up, followed by a drop 30 minutes after that. What does this add clinically to my results? The CAR can give you information about HPA axis reactivity and function, and it reflects anticipation of expected stress throughout the day. It can also pick up early HPA axis dysfunction that might not be revealed by the diurnal cortisol profile. And in this graph on the right, the AM60, which is that really high point, it's supposed to be less than or equal to the waking value, but it's unexpectedly high. And this will give you additional treatment considerations like self-care built into the morning, maybe phosphatidylserine, less coffee. Think about, how is the career affecting your stress level, or how are you coping with it? There are a lot of things you can do about this. And how do you choose between the CAR or the diurnal cortisol profile, or both? CAR is usually ordered in addition to the diurnal cortisol. So practitioners are usually deciding whether they want to add it on. And I might consider just ordering the CAR if there is stress or fatigue, but there's not any trouble with sleep. The diurnal cortisol includes evening and night levels of cortisol. So you can check if the cortisol is going up before bed, and that would interfere with sleep. And there are specific treatments you can do for that. This is a list of conditions associated with an abnormal cortisol awakening response. Think about any condition that would involve stress upon waking, or on the other hand, trouble getting out of bed. For example, PTSD, sleep apnea, and so on. As to how to interpret the CAR, in this case, the rise is low and the decline is high, and the language surrounding the cortisol awakening response can be confusing. When the decline is greater than expected, that means that the cortisol 60 minutes after waking is higher than the waking value. So I'm going to zoom into the CAR part of the graph here. There we go. Ideally, 30 minutes after waking, cortisol is supposed to be higher than it was when the person woke up. And this is the rise. And I drew a dotted line to show where we usually expect to be measuring it from. In this case, it went down. So the cortisol did not rise enough. And in fact, it dropped. 60 minutes later, the cortisol is supposed to recover back to the waking value, or even be as much as 1/3 lower. And this is called the decline. And this patient's decline is higher than expected because the cortisol went up when it should have gone down. So here's an analogy. On this picture, that red line is just where the cortisol levels should have been in an ideal situation. And then the black line is what actually happened for the patient. So a low rise is like when you didn't pull your pants up enough. And then a high decline is as if you pulled your shirt down and it didn't come down low enough. So either way, midriff is exposed. If your patient wakes up in the middle of the night, maybe 4 a.m., and then goes back to bed, sleeps until 7, when should they collect the CAR? So you want to know, are they supposed to collect their saliva at 4, or are they supposed to wait until 7? And if you wake up in the middle of the night and you're able to return to sleep until your usual waking time, you can collect saliva at your usual waking time. So 7 a.m. in this example. Just try to avoid turning on the lights because that can stimulate cortisol production. And if you have to get up to use the restroom, that is totally fine. Just keep the lights dim. And as long as you can return to sleep, it's fine to go ahead with the collection. If you do wake up much earlier than usual and you can't return to sleep, it would be preferable to collect on a more typical morning. Now we're going to talk about some pearls regarding diurnal cortisol testing and treatment considerations, especially for those who have trouble getting out of bed in the morning. The significance of the adrenal phases. This is a way to categorize the degree of HPA axis dysfunction, and it can help guide your treatment approach. So that's the whole reason we give these numbers. If you look at phase 1, that tends to be an upper range or a high cortisol at any point throughout the day. It can also involve slightly suboptimal levels. Phase 2 is more long-standing HPA axis adaptation, and you're going to have suboptimal morning cortisol. Phase 3, you'll have a low morning value and sometimes a flat line from there on. And this chart is basically those pictures, but in words. And this is how you can tailor your treatment based on the HPA axis phase. You can always include lifestyle optimization. Vitamin support can be good at any phase. Adaptogenic herbs also can be really helpful. Glandulars you might incorporate with phase 2. And then for phase 3 cases, you might be able to prescribe hydrocortisone. After you prescribe hydrocortisone for 3 months, it's a good idea to have the patient stop taking it for 5 to 7 days and then retest endogenous production and check in on symptom control. If they still have severe symptoms and the test is coming back still phase 3, you can continue the hydrocortisone in 3-month increments. You just want to make sure you're not giving more than 20 milligrams per day in order to avoid suppressing cortisol production. And if you do If you do things this way, long-term hydrocortisone is likely okay as long as patients continue to need the support, but you do want to simultaneously be working on improving the health of the HPA axis so that hopefully they're not going to need the prescription for too long. Now we're talking about reproductive hormones. And this is for our saliva tests. Why is the supplementation range higher than the reference range? These supplementation ranges are based on the work of Dr. John Lee, and they're based on how much hormone a youthful gland, endocrine gland, is expected to produce. And Dr. Lee treated patients with progesterone cream at physiologic dose ranges, and he was tracking symptoms. And by looking at when the symptoms disappeared and when bone density improved, he was able to establish these supplementation ranges. His data has been validated by our database of over 180,000 processed saliva kits. So we've been using these numbers for a long time. Metabolic syndrome affects androgens really differently in men and women. Women with metabolic syndrome tend to have androgenic excess, while the opposite is true for men. This is because when androgens approach deficiency levels in males and excess levels in females, there is a loss of muscle mass and an increase in abdominal adiposity. And this leads to metabolic and cardiovascular disease, including non-alcoholic fatty liver disease and diabetes type 2. And by the way, testosterone levels overlap in these two groups. So a woman who has high androgens will have similar testosterone levels to a male who has hypogonadism. And this is more specifically the cycle of what's happening in men with metabolic syndrome. You have an increase in adipose tissue, especially central adiposity, that promotes insulin resistance, decreases luteinizing hormone, that decreases release of testosterone, promoting more body fat accumulation. This is where aromatization happens. So then estrogen levels are going up. Sex hormone binding globulin is going up, binding more of the testosterone, so less of it can be active. It's a little bit more complicated in women if you look at this chart, but this also incorporates how symptoms are produced. So insulin resistance leads to elevated blood levels of insulin. That decreases sex hormone binding globulin, increasing the production of androgens from the ovaries and disordering the release of FSH and LH, increasing androgen production, and so on. If you're planning to prescribe hormones, it's crucial to understand the difference between progesterone and progestins. Progesterone is on the left, and then a common progestin is on the right. Bioidentical progesterone shares the same molecular structure with the hormone made from the body. But progestins have differences in the molecular structure, and that leads to different effects on the body and different risks. Progestogens is an umbrella term that means hormones that affect progesterone receptors. Both progesterone and progestins are progestogens, but they have really different effects when they do connect with those receptors. And to highlight these differences, bioidentical progesterone can be safely supplemented during pregnancy to help prevent miscarriage in some cases, but progestins are typically used to prevent pregnancy, and certain types of progestins might even cause birth defects if they're taken by someone during pregnancy. Bioidentical progesterone is available over the counter, via compounding, or even as a conventional prescription like Prometrium, and progestins are what are in HRT and also in birth control. And a literature review concluded that natural progesterone is protective and preventive of breast cancer and may also be helpful in preventing cardiovascular disease and stroke. Progestins have been found to impart increases in rates of breast cancer, coronary heart disease, strokes, pulmonary embolism, and dementia. So they're very different. Now we know why to choose bioidentical progesterone, but how do we dose it? So if you're using topical progesterone, the dosing depends on the body weight of the patient. And if your patient is premenopausal and hoping to conceive, only dose it during the second half of the cycle. Luteinizing hormone going up induces ovulation, but supplementing progesterone too early can inhibit the pituitary secretion of LH. And that's why we want to wait until after ovulation to supplement the progesterone. If there's not any interest in conception, days 7 through 28 are fine. And postmenopausal women can use progesterone every day. So now you're probably wondering, what about dosing for men? Progesterone is not just for women. Men produce progesterone too, and it affects the health of men's brains, bones, prostate, and sperm. You might consider progesterone supplementation in men with prostate symptoms like decreased urinary flow or to treat BPH. Progesterone inhibits the proliferative effects of estrogen on the prostate, and it's often combined with testosterone supplementation for men because it inhibits 5-alpha reductase. And a typical dose of progesterone for men is about 5 to 15 milligrams per day. Hormone testing while using oral contraceptives can elucidate how the pill is affecting hormone balance, but this tends to be very predictable. So I guess I wouldn't test hormones if someone was taking the birth control pill because the pill suppresses ovulation. This leads to progesterone insufficiency and often low E2 and suboptimal testosterone. And the progestins in the contraceptive pill are not measured by the laboratory test systems. So the result is going to reflect the patient's endogenous production, and that's been suppressed by the pill, predictably. So can you supplement progesterone for women who are taking birth control pills and have progesterone insufficiency? The problem is that there's competition at the receptor site, and that might offset any benefit of supplementing with bioidentical progesterone. And there's also the potential to decrease contraceptive efficacy, but there's just not much research on this combination. It might be okay to use bioidentical progesterone for patients who have an IUD because that has more than one mechanism of action to prevent pregnancy. It's also possible that the pill is the cause of the low progesterone. So stopping oral progestins might be a consideration. So there are 3 different types of estrogens. If you are wondering, estradiol is the most common. Usually when we say estrogen, estradiol is the one we're talking about. It's important for reproduction. Estrone becomes the predominant estrogen after menopause. High levels can be associated with increased breast cancer, increased endometrial cancer risk, but low levels can be associated with menopausal vasomotor symptoms, osteoporosis. Estriol, E3, is the weakest estrogen, but it weakly binds to estrogen receptors and it protects from the proliferative effects of the other estrogens, and it can be supplemented vaginally to help with vaginal dryness. Testing all 3 of these estrogens allows you to calculate the estrogen quotient, and you might consider this option in women over 45, people who have a personal or family history of reproductive system cancers, but typically not men. There's not a reference range for men for the EQ. There are 2 different ratios on our saliva testing, the EQ and the progesterone to estradiol ratio. So what's the difference? They're both clinical ratios that help you approximate the risk of proliferative issues and target supplementation to reduce that risk. The EQ has a reference range only for women, but the PGE2 is relevant for both women and men because, remember, men might be supplementing progesterone to try to decrease risk to the prostate. Sufficient quantities of estriol, which would be indicated by an EQ greater than 1, might help antagonize the proliferative effects of estrone and estradiol. A low EQ, though, is not necessarily associated with any symptom pattern. The PGE2 gives you a target to help minimize prostate risk in men and to help protect the breast, heart, and bones in women, and also can help improve progesterone insufficiency symptoms. So the PGE2 can be associated with symptoms. Progesterone sensitizes estrogen receptors. So if you achieve an in-range progesterone to estradiol ratio for women who you're supplementing hormones for, that might allow you to minimize how much estradiol you need to use in order to provide symptom relief for your perimenopausal and postmenopausal patients. And when you supplement hormones, looking at both of these ratios are just two different ways you can do so with that. You can give bioidentical hormones more safely when you look at these ratios. New topic, melatonin. It's another hormone and it helps us with sleep. We all know this. What if your patient has trouble falling asleep at night? Why is the melatonin high? The most common reason is recent supplementation with melatonin or 5-HTP. Also taking SSRIs or SNRIs as they increase serotonin, that might be involved because serotonin converts to melatonin, so that can lead to high levels. Another reason could be lack of light exposure. So someone who doesn't go outside or perhaps night shift workers, that can also lead to higher melatonin levels. Phytomelatonins from the diet could be a factor, and I listed a few foods that have particularly high levels of melatonin. And last, consider that insomnia might not be due to low melatonin. There are a lot of reasons for insomnia, and melatonin is not the only factor. Elevated melatonin levels can be addressed with morning exposure to light, spending more time outside, light box therapy, and then also consider neurotransmitter testing to check for that elevated serotonin. The question of safety of melatonin for children comes down to two things, whether there are serious side effects and whether it works, and then also if it could affect the timing of puberty. And the research on melatonin in the general population of children is lacking, but we do have a number of studies involving children with autism or ADHD diagnoses. And the concern that melatonin might affect pubertal timing comes from the fact that melatonin levels decrease as children reach adolescence, and this corresponds with changing Tanner stages. So it's thought that melatonin plays a role in puberty onset, and the worry is that if you supplement melatonin, you might be interfering with the decline that they're supposed to be having at that time. These are the studies on efficacy involving children with ADHD or autism diagnoses. Their ages were between 2 and 17, and they were given anywhere from 2 to 10 milligrams of melatonin. And the adverse effects included feeling groggy in the morning, low mood, headache, sweating, laziness during the daytime. I wonder if perhaps these effects could be avoided if they were given a more reasonable dose, like perhaps 0.5 to 1 milligram, which is usually enough for an adult. Only 3 studies tracked puberty onset in relation to melatonin use, and it was a secondary outcome measure. One study looked at 59 children aged 6 to 12, and they used melatonin for at least 6 months or more. 19 of them reached puberty during the study, and there was no difference in timing compared to the population norm, but that's a really small group to look at. 10 years later, only half of the kids from this study completed a follow-up, and 31% of them reported a perceived delay in sexual maturation. So that means that in their own opinion, the kids had a delayed puberty as they remembered it a decade later. There was another group of researchers that looked at Tanner stages for 46 of the kids from that original trial, and they determined that long-term melatonin did not affect pubertal timing. Here are those research studies. You can look at them later. And I know I already went over 50 questions, but I have 2 bonus questions to share. They're really quick, but they're also really important. Question 52. Patients on hormones need to follow the proper dosage interval before saliva collection. Doing this wrong can make it really hard to interpret the results and to interpret if the dose is right. So for patients on transdermals, they need to stop 12 to 24 hours before collecting saliva and not reapply throughout the day of saliva collection. Sublingual hormones need to be stopped 24 to 36 hours prior, followed by 2 glasses of water. Oral hormones can be taken the same day. Hormone dosing that's done like weekly or biweekly or every couple of months, you test hormones halfway between those doses. So to figure out if your patient properly timed their hormone dosing prior to saliva testing, you can look at this questionnaire that they fill out when they're taking the test. This person used a topical hormone less than 12 hours prior to testing, so they actually got that one wrong. The other one was correct. And this is the last question that I get all the time. When do you test patients' saliva hormones if they have really irregular cycles? So this chart spells out what to do if they have long cycles, what to do if they have short cycles, how to calculate based on ovulation pain. But the trickiest situation is if the period has been missing for 2 months or more. And in that case, you can have them collect the sample and freeze it. They wait 2 days. If they have any bleeding during that time, they can thaw it out, empty out the tube, rinse it in warm water, let it dry, and then collect the following month. If there was no bleeding during those 2 days in the freezer, just send it in, it's fine. Now you know the answers to our 52 most frequently asked questions about neuroendocrine testing. And before I'll go, I'm going to answer a few new questions that came in from attendees.